I'm going to focus today on immunology assays. That's kind of the field that I know. And I know you heard a lot about diagnostics already yesterday, and Steve Hoffman told you about some of the perils that can happen with diagnostics. I'm going to focus more on the content today and how we can do that better in terms of new immunology assays that might be useful clinically. And to start with, I think we should examine the current state of immunology diagnostics or immune monitoring diagnostics. And our objective here is see if you can name even one test of the immune system that is used clinically today. And then what can the drawbacks of that be that, things that we could improve upon. So I'll give you a short list. It's not too hard because there aren't that many. So really probably the best example of an immune-based test that is done every day, countless times in hospitals and clinics is the complete blood count, or CBC. It can be done with a differential that differentiates monocytes from lymphocytes. And it's a cell counting assay, okay? So really not that detailed. You have to go to the differential test in order to even tell monocytes from lymphocytes. There's no differentiation of different kinds of lymphocytes, T cells, B cells. There's no examination of subsets of NK or dendritic cells or anything else, but it's just 5 blood cell types. Now we can get a little more detailed. If we suspect HIV infection, we can do CD4 counting as a monitor to make sure that your CD4 cells aren't depleted, that you go on therapy in a timely manner, and so on. But really that's only done in HIV disease, and it's only really counting one cell type. Nothing so far is testing the function of your immune system, just counting cells. However, if you have allergy or a suspected autoimmune disease, there is at least one functional test that I can think of, and that's a hypersensitivity test. We do it by pricking your skin, very modern technique. Okay? Prick your skin and see, well, how big of a red bump do you make? Again, only do that in situations of hypersensitivity. It's almost never done in terms of gauging your immune response to something else, to infectious disease, to cancer, what your risk might be for anything else. It's really in a very restricted setting. Similarly, we can look at antibodies. So there are antibody tests out there that will measure specific antibodies to things like double-stranded DNA and maybe a few other selected autoantigens that are particularly diagnostic of a given autoimmune disease. But if you don't have that disease or you're not suspected of having that kind of a clinical situation, you won't get any antibody testing done. So it's a very short list with very few functions and very few things that we actually measure in the immune system. By contrast, what can you measure about the cardiovascular system? You can measure lots of things. There are some very intricate tests of heart function, of vessel dilation, of cholesterol and other lipids, and the list goes on and on. You can really assess the cardiovascular system at some detail. Is the immune system less important? Probably not, but we don't do very much testing of the immune system in the clinic. So the other thing about these tests that I just listed, they tend to have one or maybe a very few analytes per test. So I told you 5 blood cell types for the CBC. CD4 count, it's one readout for the CD4 testing. Yes, you get some other few things because the manufacturers of those tests like to throw in some other cell count, but really the clinicians just care about the CD4. And so it is with most of these things. We get one test, one readout, maybe a couple readouts. And as I already mentioned, they're mostly looking at cell counts and not functions. And this comes from the paradigm that you want to figure out what is the biomarker of a particular outcome, whether that's diagnosis or whether that's prognosis of some other clinical feature. But you're going to measure one thing and have it relate to one outcome, and then you have a test. And the system does not reimburse for extraneous readouts. There's nobody's saying we should measure everything that we can because it might be important to the system. That's not the way diagnostics work, right? You measure one thing, you show the relationship, and now you have a test. So let's go on and see how that might be made better. But first, here's the other thing that I don't like about our current system. Not only is it one test, one result, but it's pretty much one tube of blood per test. A whole tube, 5 cc's usually, okay? And one of those gets used to do your CBC, another one gets used to do autoantibodies, etc. You know how much is actually used in the test? It's probably 1/10 of the volume of blood that is drawn for each of those tubes. Each tube is a different type of anticoagulant, and you're measuring these few things in the end from all this blood. And if you're in the hospital, they're going to do this to you every day. Pretty soon you'll be anemic. And most of the blood and all the information that comes along with it is wasted. So I call this modern day bloodletting. So, this is module 1. I was told to make 3 modules, so this first one's pretty short. There's very few clinical tests out there in the immune monitoring space. The ones that are there have some serious drawbacks in terms of what they can measure and how completely they can measure things. And we draw a lot of blood just to do that. Okay? So any questions so far? We'll go on to module 2.